Good afternoon. Welcome to Bariatric Friday. Today is March 10th, 2023. My name is Kemal Erkan. I'm the chairman of American Surgery Center and United Medical ACO. I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing great, Kemal. Again, great to be back for another session of Bariatric Friday.
Absolutely. So today we are going to discuss the type of surgeries. We covered these cases, these topics in different ways, but our audience is in some cases different, and sometimes the way that we explain, people are able to pick up more stuff. Now, as we know, for morbid obesity, the most efficient, most effective way of solving morbid obesity is bariatric surgery, and there are several different options. And then when a patient comes to us, they already have their mind up and then they want to get XYZ. But when we talk to them, the first consult, things may change. But we don't make that decision based on preference, but we make those decisions based on the conditions that patients may have. And that's why we are going to actually kind of go through those now. You know, Dr. Irgau, in the last couple of weeks, when we have, there are some patients, they still have this issue of they're about to get one, and then they're like, oh, no, I don't want to really do that, and I'm going to do this. Then we're like, look, you have to watch one of these sessions to kind of maybe rethink about what's happening. So these become more and more useful these days. So, well, let's talk about the type of bariatric surgeries. You are on.
Absolutely. Absolutely. Actually, talking about the sessions that we have, Kemal, and how we go through similar topics, after one cycle, people watch them. They find them very engaging and interesting. I was actually talking to a patient who is going to have surgery in about 2 weeks' time. She was in the office for her surgical clearance, and she mentioned how she watched our last episode of the day of surgery. And it wiped out all the questions she had for that day, for the visit, because we were able to go through. But another thing, she was very impressed with your interest, particularly, on bariatric surgery, on the treatment of morbid obesity. She wanted to know whether you were an associate of mine, a clinician with me at surgery. And I told her you were the guy who made things happen for us, our CEO.
I'm the other guy.
But she was very, very impressed with your interest, and depth of knowledge. She wanted me to pass that on. Absolutely. So we are going to talk about types of surgery today. So first of all, why surgery, right? This is actually a question that comes up, particularly from people who don't struggle from obesity themselves, or who don't struggle from as much obesity as our typical patients. Well, the simple answer is that surgery is currently the most effective treatment we have for morbid obesity. And we've identified morbid obesity as a disease currently, not just a disease, but a dangerous disease that is associated with a plethora of other medical conditions that ultimately lead to shortening of a person's lifespan. So it is a life-threatening condition, and surgery is the most effective treatment we have currently available, and that's why we do surgery. And not only that, but we have managed over the years to improve the safety of surgery, so that all the surgeries that we perform right now have a safety profile that is comparable to many other fairly common procedures like gallbladder surgery or hysterectomy or knee replacement surgery, essentially. And what are the indications? What do we call severe obesity or morbid obesity? As we've said many times, we talk about a weight that is excessive. A person whose body weight now is about 100 pounds or more over their ideal body weight. That person is really struggling tremendously under the burden of that weight in their daily activities. But as I said, because they are in danger of serious illnesses like type 2 diabetes, high blood pressure, and sleep apnea. All the surgeries that we perform essentially are some type of rearrangement or modification of the digestive tract. That's really the principle of the surgeries that we perform currently. The most common surgery that we do is the gastric sleeve or the sleeve gastrectomy, and I will talk about that in a minute. Then there is gastric bypass, which is a procedure actually that has been the gold standard for many years prior to the popularization of the gastric sleeve. But we do also do the gastric band, also less commonly than we used to do that in the past. Another procedure which is done less commonly is the duodenal switch or biliopancreatic diversion, and I will mention that as well. And all those are performed in our practice. So if you look at similarity between this procedure is that all those procedures to some extent reduce the size of the stomach that receives the food, right? That's actually a constant for all those procedures. The stomach is made smaller, whether it's by the lap band, where a ring with an inflatable inner surface is placed around the upper portion of the stomach to create a virtual pouch, or the gastric sleeve, when we actually remove more than 80% of stomach, and then the stomach becomes the shape of a slender banana, essentially, or the gastric bypass, where we actually divide the stomach to create a very, very small pouch, or the biliopancreatic diversion or the duodenal switch, which is in the stomach version is actually similar to the gastric sleeve, although it does have other additions. So there is this commonality to this procedure. All of them create a small stomach. So let's start with the gastric sleeve, right? The most common procedure, very, very popular procedure. And with this procedure, essentially what we do is we cut the stomach so that a larger portion of the stomach, which is known as the greater curvature and fundus of the stomach, are removed completely. So by definition, this is a non-reversible procedure because we are taking out a portion of that organ, essentially. And the person is left with a very slender stomach. The procedure, like all the other procedures, is performed laparoscopically. And this is very important because it allows us to do outpatient surgery. It allows the person to recover from the surgery very quickly. And it allows the person to have much less wound-related problems like wound infection or hernias, essentially. Okay, so with the sleeve gastrectomy, the stomach is a lot smaller. Now, the sleeve gastrectomy is right now in the United States the most commonly performed procedure. And when we first introduced it, Kemal, I was surprised on how quickly it took off, right? People intuitively liked it, accepted it. And if you think about it, people associate their obesity to this constant eating and hunger that they struggle with. And here is a procedure that takes that away completely because it makes the large stomach, distensible stomach that continuously expands to receive more and more food, now is restricted. It cannot do that. The person will have a few bites and they feel full. Not only that, but hunger is also under control. That really appeals so much to patients, Kemal, that this procedure has become, in most places, the procedure of choice for most patients. And in our center also, I'm sure you have the figures, that's the procedure that we do much, much more commonly than the others.
So, so we were talking about sleeve, right?
Yeah.
So, although I think the term sleeve is probably wrongly chosen, so because for a long time I thought we were actually cutting the stomach and then just wrapping it with that extra one and then they were just putting the stitch. I'm like, so that's why they were calling it. And then one day when you actually kind of show me exactly how it's being done, I'm like, oh, then why are you guys calling this sleeve? So it's really not a sleeve, right? So, but it's kind of like once I understood exactly how it's being done and what it does, I think part of the one of the things that we do need to mention, the stomach is not an independent organ, so it works with the brain directly, and they just talk all day long. A lot of signals are being sent back and forth, and it just says, do this, do that, do more, do less. No, don't eat that. Just eat more ice cream, eat more pasta, eat more pizza. Right? All these things are being communicated. It's not something that stomach is deciding on its own. It's telling the brain to do that, and then that's how we end up doing it. So when we cut this piece, so when you explain that to me, I remember so well. why it was actually successful. It's not just making the stomach smaller, because that thing actually, small part can still expand. But when we are able to take that part, the signals, the hunger signals are much less. So then it's not like something that we have to really do. There's no extra effort needs to be done, but the traffic is the heavy traffic is no longer the case. So that's how this works more efficiently, just other than the small stomach. So is that kind of like
Absolutely. Actually, that is really the root of the answer of why surgery is effective, Kemal. It's not just a reduction in the volume of food that the person eats. It's also the transformation of the pathways of communication between the digestive tract and the brain. That is really critical. And that's where actually a lot of the research is going on right now, to ultimately find a medication that will do what the surgery is doing right now, right? Understand those pathways. They are extremely complex pathways. Of course, people know about ghrelin, which is this hormone that is known as the hunger hormone, which is produced by this big portion of the stomach that we are removing, and its levels actually go down to almost zero after that procedure, although they start to rise again. So essentially, more than ghrelin, there are many other issues. And of course, it is actually easy to understand this, Kemal, because many people actually do diets with the reduction in their calories comparable to what a person after sleep eats, right? And yet the person with the sleep will be losing weight effectively, fast, and well. And the person who's dieting with the same amount of calories is stuck in that loop where they cannot lose weight anymore. So it's not just about reducing how many calories that person ends up putting. It's also changing the metabolism, changing those communication means through which the digestive tract and the brain interact to ultimately determine the energy requirements of the body. And clearly, as it evolved, through thousands of years, our body evolved really to conserve energy as opposed to lose energy. Because, for most of our existence as humans, the greatest threat to our existence was lack of food. So we had to evolve a body that was good at holding on to whatever we ate for as long as possible until the next meal was available. And that body that we inherited from our ancestors is still here, the same. And yet our environment has changed completely, where now it's not lack of food which has become a threat to our existence. Excess food has become a threat to our existence, essentially.
The food is everywhere. So
yeah, everywhere and anytime, right? You don't have to go. It comes to you now.
It comes to you.
It comes to you.
No effort. Now, if the patient, let's say 37-year-old female with no diabetes, BMI 47, no reflux, it's a perfect candidate for gastric sleeve. So now we'll talk about gastric bypass. Tell us about bypass, and then I have a couple of questions.
Absolutely. So gastric bypass is different from the sleeve, chiefly because now not only we're dividing the stomach to make a small stomach, but we are rerouting the intestine as well. So not only the person will be receiving less food in a smaller stomach, but that food will be processed differently now because we have moved the position of the intestine. So the stomach, as you show on that picture on the right, essentially has been divided high up, where a small stomach now is still connected to the food pipe, but completely detached from the rest of the stomach. And then what we've done is we've divided the intestine lower down, and we brought a loop of the intestine and connected it with that little stomach. So food, as depicted by that blue arrow, now will go straight into the intestine. It will bypass the larger stomach and the early intestine. And the acids and juices that are critically important for digestion and absorption will still be produced by the larger stomach and the early intestine. And as you're depicting them by that green arrow, they will be going down that route and catching up with the food lower down, right? So now that early portion of the intestine, which is extremely active in getting the food absorbed very quickly, it will be deprived from any contact with the food. The food will not be contacting that early portion of the intestine, which means that now we are interfering on how the intestine absorbs the food as well. Now, this procedure is the classic procedure. It was a gold standard for many years. When I was first training in bariatric surgery, we just had the gastric bypass mainly. And that's what we offered most patients. And it is a great procedure. There's no question about that. The point that we are bringing right now is that there is actually a downside to rerouting the intestine. And that downside can be avoided by doing the sleeve for most patients, right? Now, clearly, there are some patients on whom the sleeve may not be appropriate, but these are not very many. The vast majority of patients who are trying to achieve significant weight loss can achieve that by and large with the sleeve gastrectomy. But the gastric bypass is also a great procedure and is still avoidable. For instance, for patients who have problems with their food pipe related to severe heartburn, for instance, the gastric bypass may be preferable. And the downside of rerouting the intestine clearly is the fact that now you're interfering with the absorption of necessary nutrients like vitamins or micronutrients as well. And if that can be avoided, of course, it is preferable.
So I think the idea of surgery and what happens after the surgery, we always say that this is a huge change in someone's life. So if the conditions are right, we want to make sure that this change is not as big as it should be. It should have been. So in the gastric sleeve example, our stomach is still functioning the way that it was before, but we are just making it smaller. Versus in the gastric bypass, there's no going back from that in terms of once I have the bypass, it's a more complicated than sleeve, but it's more major in a way that it's actually the stomach is not doing its function anymore. So then everything is way too limited. So what you can eat, what you can drink, how much you can eat is going to be a lot limited. So, but I know that this works better for patients with reflux issue and then diabetes. Now, can you explain? Maybe you did it, and I was taking some notes, but I want to make sure that we are not missing that. Why is reflux and diabetes with those conditions? Why is this a better solution?
Absolutely. So, first of all, we have to clarify this issue, Kemal. It is very important to understand that we're talking about a degree of reflux or acid, heartburn that is very, very severe. That is, on multiple medical medications that the person may have actually developed already scarring and inflammation, severe inflammation of their food pipe because of the acid. We're not talking about the run-of-the-mill acid reflux that most people have, for which they have to take Tums or even take antacids on a regular basis, but reasonably well controlled. Now, for those people who have the really severe type of acid reflux, the gastric bypass is better simply because it is going to be taking away the acid-producing stomach from the food pipe. If you go back to the diagram that we had earlier about the gastric bypass, you can show that after gastric bypass, the food pipe is not in communication with most of the stomach. Therefore, the acid from that stomach will never be able to reach the food pipe again. Whereas with the gastric sleeve, the lower portion of the stomach is still in communication with the food pipe, so reflux could persist. Yeah, as you can see with that diagram, the larger portion of the stomach is totally now disconnected from the food pipe. The acid cannot go back there anymore. So not only gastric bypass is a better procedure for people who have severe reflux when they're looking for bariatric surgery, but also, Kemal, there is the other situation now where we have patients coming for surgical treatment of acid reflux that's been severe, and they also have obesity. In this case, rather than recommending the traditional anti-reflux, anti-acid reflux procedures, we actually recommend gastric bypass. So gastric bypass has become a type of anti-reflux procedure as well. So we're talking about specific situations. And as I said, the key here is that the acid now is secluded away from that lower portion of the food pipe, and therefore refluxing acid into the food pipe cannot happen any longer. And that's the key. Now, let's go to the other issue about diabetes, right? Well, many years ago, one of the pioneers of bariatric surgery published a paper that was titled, "Who Would Have Thought a Surgical Procedure to Cure Type 2 Diabetes?" It was really a very, very interesting paper because he was a bariatric surgeon showing how many of his patients who had gastric bypass and who were diabetic after the surgery were no longer diabetic. Essentially, they've been essentially cured from diabetes. And in some people, actually, this effect is dramatic, Kemal. I mean, I remember, for instance, years ago when we used to do a lot of inpatient procedures at the hospital, we used to have patients coming in the night before for gastric bypass, diabetic patients, and we used to consult the internal medicine, the endocrinology people to manage their insulin. So they would be on different, units of insulin, and yet we do the surgery, and the day after surgery, they would not need any insulin at all. The diabetes just goes away like that before they've started losing an ounce of weight. So there is something drastic that happens when we make that rerouting of the intestine so that the early portion of the intestine is not in connection with the food anymore. Now, this dramatic change does not happen with everybody, but clearly gastric bypass is a very, very good procedure for type 2 diabetes. It is important for us, however, to say here, Kemal, that the effects that we see on diabetes are seen with the gastric sleeve as well. You may have to wait a while for the person to start losing weight, but gastric sleeve is also a very effective procedure for type 2 diabetes.
So, like in that case, like almost like the age becomes the main factor on deciding which procedure would be best, even if someone has diabetes, because we won't do the case until the diabetes is controlled. So then if someone is 37-year-old again, can go back, can do the sleeve, they will definitely benefit from the weight loss. But then let's say if it doesn't work, then there's still time to go to the next level. Like bypass in this case would be the next level. But if you do the bypass too early on, there's no going back. So and then when you put all the benefits and
risks and benefits,
it just makes it pretty straightforward in my opinion. So that if I see someone in certain age group with certain conditions, of course, at the end of the day, this decision needs to be made with the surgeon and the patient. But just for patients to better understand why we would actually ask them to do one procedure over the other one, it's just because it's better for them with the for their health, and also if there's a less riskier option, why not? Right? So
absolutely. So yeah, that's a great point. Earlier in life, patients in their early 20s, you would be much more reluctant to offer the gastric bypass nowadays when you have the sleeve available, because that person will be exposed for so many more years to the potential downside of malnutrition, vitamin deficiency, with potential hair loss, weakening of bones, poor healing of wounds, as well as potential nerve damage if they're not careful with their vitamin intake. So, and also that the point that you made about the finality of the procedure is very important, right? I explain to patients very often by saying that the gastric sleeve is almost like a middle of the road procedure, right? Whereas the gastric bypass is like the final stop, right? There is not very much you can do or go from the gastric bypass, whereas the sleeve is actually amenable to be changed into gastric bypass if necessary, right? So you haven't played all your cards, with the gastric sleeve compared to the gastric bypass, and that's an important consideration.
You're able to achieve that with less risk, less complication, and less changes in day-to-day what we are doing. So that's really important. So it's not just the risk and the complications, but every day I have to do certain things differently because it's not the same as the sleeve versus bypass. The bypass is, as we explained, the stomach part is bypassed. That's why it's called. So that's actually, they did a good selection on the term. So it's being bypassed. So now we used to do a lot of gastric band, and every once in a while I see patients are insisting on this. And what I see in the last 5-6 years is a lot of band removal because they are actually going to the next level. So I think you should explain what's happening with band and why we do less. That would be probably helpful for our patients.
Absolutely, absolutely. So clearly, the decision as to which procedure has to be done ultimately will come down to the wishes of the patients, provided there are no major contraindications to their choice. And in my view, I always say to patients that when they are faced with morbid obesity, the worst choice is to do nothing, right? I think that is clearly very important. Having said that, there are clear advantages to the gastric sleeve or gastric bypass when you compare it to the band, right? The gastric sleeve or the bypass, first of all, are much more powerful in inducing significant weight loss. So when you're looking at somebody that needs to lose close to 100 pounds, they are more likely to achieve that with one of those procedures. We call them stapling procedures as opposed to the gastric band, where we are placing a device around the upper portion of the stomach. From a patient's point of view, there is an appeal to the gastric band, Kemal, and that is we are not rerouting any organs. We're not taking away any part of the organ. We're simply placing a device that can be removed. So conceptually, the patients find this more appealing in terms of really not burning any bridges, so to speak, right? They want to do something that they can get out from, so to speak, right? Well, and based on that, when it first actually was popularized, we did a lot of gastric bands. And I have to tell you, I still have patients that I have operated in the early 2000s, and I placed the band, and they still have the band, and they're still very successful. So, but we're talking about, in the vast majority of cases, however, there are problems with the gastric band where patients end up having the band removed, particularly because the quality of life tends to be difficult with, unpredictable throwing up or difficulty swallowing, or just going back and forth between the band being too tight or too loose. Remember, the band, is this little ring, and on the inside of the ring, there is an inflatable portion that we're actually able to fill with saline, or we're able to remove saline from. So it's an adjustable band. So we can tailor the tightness of this ring according to the particular needs of the patients at that particular time. But sometimes this doesn't happen precisely, right? So it's a band over time could become too tight just because the reaction of the stomach wall over time leads to thickening of the stomach wall itself, which makes the opening within the stomach itself smaller. So even though they haven't had any adjustment for years, suddenly you will find some patients coming into the office saying, hey, I cannot swallow anymore, right? And we tell our office all the time that when we have patients with a gastric band that say they cannot swallow, they have to be seen that same day. It's very important because it's very uncomfortable. We have to be able to see those patients remove the fluid so that they can swallow and get hydrated, essentially. So these are the issues with the gastric band. Clearly, the gastric band is still an option, and for patients who really see no other comfort, for themselves, it should be available, and we should be able to work with them. And as I said, in some patients, it works marvelously. And as I said, I do have patients who had the band for almost, actually 20 years now, and they've done well. They've done well. But it's not certainly my first choice at the moment, because we can achieve a lot more with a relatively safe procedure like the gastric sleeve.
So actually, since I'm not a clinician, but once I understand the technical part of these, immediately what I see is, okay, I know how sleeve works. So there are certain things that's not going to be part of me anymore. So on the stomach. So then I know there's a smaller part where the band seems like it's just slowing down the process, but it's not stopping. It's almost like, I mean, you can correct me if I'm wrong with this one, but I'm just saying this from the non-clinician standpoint. So, like, because you put the band, but the stomach is still doing what it was doing before. In terms of
it does. So there are actually some other mechanisms with which the band works that are not clearly defined. For instance, the actual pressure of the band on the outside of the stomach and some of the nerves that run in that area does impact metabolism to some extent. So I wouldn't call the gastric band necessarily a metabolic procedure, compared to the sleeve or the gastric bypass, but there is some impact. So it's not just about restriction. There are other advantages as well. And that's illustrated in some of the patients who do absolutely fabulously. I mean, I have patients, Kemal, who have lost 150 pounds, 180 pounds, and kept it off for over 10 years with the gastric band. So it does work in certain settings. But when you look at its application in the vast majority of cases, we struggle with the quality of life and with the fact that complications occur requiring removal of the band. Clearly, obviously, with placement of the band, like all these surgeries, but also specifically with the band, a follow-up is very, very important because it's a device that you have inside, and that device has to be monitored with, on a regular basis. And of course, we try to get our patients to understand that as well. But just looking at it from the patient's point of view, though, Kemal, I mean, what you're saying, about the intuitive understanding of which is better is logical. But you have to also remember, Kemal, that there are probably 90 patients out of 100 who still do not want to have any type of surgery when it comes to treatment of morbid obesity. So we have still a lot of work to do to get those patients in. And if the only thing that they will accept, is the gastric band, then in the circumstances we have, to educate them and then obviously work with them as well.
No, that's so right, because what I was about to say, that I wrote it down here, what is not an option is not having the surgery, but there are so many different surgery types as an option. So yes, in this case, the band is it's a sufficient, effective way to do it. Now, I want to cover a couple other things very quickly.
I can probably talk a little bit about the duodenal switch, Kemal, which is a procedure that we do much less, but it is also avoidable. It is a much more complex procedure. Actually, you could consider the duodenal switch, from a conceptual point of view, as a combination of the sleeve and the gastric bypass. Actually, it is a combination of the sleeve because the first part of the duodenal switch is a sleeve. What you do is you cut the stomach and remove a big portion of the stomach, leaving a slender stomach. But in addition to the sleeve, you also reroute the intestine, but you reroute it in ways that are even more drastic than the ones you do with the gastric bypass. So in terms of results, actually, it does show much more significant weight loss compared to the sleeve and the gastric bypass, just because of the drastic, changes that we entail. And there are some patients who really are on the high end of the body mass index or the weight, or patients who've had the sleeve but haven't lost as much as they needed to, that the duodenal switch can become like a second stage procedure for them, where the sleeve has already been performed and the duodenal switch can be added. Now, of course, the more bypassing of the intestine you do, the more you increase the downside of the gastric bypass, right? Like I said earlier on, the inability to absorb, nutrients properly has its downside, particularly when that exposure is a lifetime of exposure. So patients have to be absolutely followed up closely. They have to be able to show commitment to taking vitamins and nutrients regularly. Occasionally, there are other issues as well with the duodenal switch, like diarrhea, which may be difficult to deal with. But again, like in any area of medicine, Kemal, the perfect answer would have been not to have the problem, right? You're not ill, you're not sick, you don't have obesity, right? But once you have that and you are providing a medical treatment, the doctor is not faced often with a solution that's 100% better and a solution that is 0%, right? We have risks and benefits. We have downsides and upsides of each option. And our job as professionals is to guide our patients through that and let them see, that on balance, the benefits have to outweigh the risks of any treatment that we provide them. And that's how we base our guidance as well when we are in consultation for bariatric surgery.
So what's clear is that these decisions have to be made with the surgeon. And mostly in our first consult, because it's a big undertaking in many cases. So patients really need to understand exactly what they're getting into. Now, Dr. I do want to cover our communication channels. So we made an update on our website for our patients, because I know that our existing patients are also watching these. One of the changes is that here is the how to make a schedule. So instead of just giving the phone number as an option, now it is 3 different options. So they can use a QR code for the regular patient portal, and then this will be updated on Monday to the patient inquiry. And then if they have to, they have no choice, but they don't want to call us, that should be the last resort here. But I just want to show the form very quickly. This form is available for, it will be available through the website. So basically, all they need to do is, instead of being on hold for 15 to 35 minutes, here is, you want to receive a confirmation. And because we do this for 2 different practices, and you need to choose, okay, here is CHRIAS, and then CHRIAS has these providers, and then reason for the call, and the patient name is, this is the second time doing this today. So then date of birth is, so then callback number is, and the email address. So once you put all these, then you'll get a confirmation, and then the latest in 24 hours. But if it's done before 2 p.m., most likely same day. Otherwise, for the next morning, you will be getting a call, and you'll be getting a confirmation, as just like I received it here. And we actually covered this just in our earlier session today.
Great. Wonderful.
It will say the provider and the ticket number. So then this will help us to increase our communication needs. As many people know, patients are not calling us like every 15 minutes. They call us at the same time. And where even if we hire 3-4 more times people, it's not going to be enough. But best would be, in your convenience, just tell us when you want to be called, and then we'll be calling you back. And if there's any emergency, you really need to go to either urgent care or the emergency room anyway. So hopefully this would help our patients to kind of more efficiently communicate with us. This is another good session. Dr. Irgau, thank you for joining us and joining us. We'll be back next week with another topic. And until